All right, so a little bit about clavicle fractures. First of all, we see this mainly in young males and older females. That's the demographic that we see this in. It's a common fracture, in the studies, 2 to 10% of all adult fractures. As far as the clavicle itself, you can see that in the drawing that it's an S-shaped bone. Curvature does vary though, and you'll be in the operating room, and as you'll see, we use these pre-contoured plates, and sometimes they fit very well, and in other cases they don't fit so well because the curvature varies. But most of these occur in the midshaft, about 80% in the midshaft of the bone. So, and does anyone want to take a stab at these deforming forces? When you see a clavicle fracture, typically they're displaced, and then they're oftentimes shortened. And does anyone want to take a stab at what those arrows represent? Well, this is your sternocleidomastoid, which is going to pull this fragment proximally, and then your pec major is going to pull the shaft, and with it the lateral aspect of the clavicle medially, and then you have the weight of the arm that's going to lead to displacement here, as the weight of your arm is pulling that distal segment distally inferiorly. So that's why you see these fractures displaced in this manner. So as far as treatment goes, historically we used to say, oh, just treat them all non-surgically, certainly up until the 70s and the 80s. And the thought was that everyone does fine, and there's not really any issues. But as we've seen, that there can be, certainly not everyone does do well with non-surgical management. And the things we would worry about are non-union rates being 15 to 20%, a loss of shoulder strength that's not insignificant, like 20, 30%, and then a large portion of patients, 42%, still had symptoms after 6 months. However, primary surgery is not proven superior for all, and it's not universally accepted. There's still debate about the treatment of clavicle fractures. This was a classic study that we should all be aware of. It was the Canadian Orthopaedic Trauma Association. They published in JBJS back in 2007. But kind of a classic, it's oftentimes referenced. Randomized 132 patients with displaced fractures in which there was no cortical contact to open reduction internal fixation versus non-operative treatment. And the ORIF group had better outcomes. There was about a 16-week time to union versus 28 weeks in those that united in the non-op group. And then the non-union rate was significantly lower at 3% in the ORIF group versus about 14% in the non-op group. So the things that we want to consider as far as assessing fractures for whether they do better with surgery versus no surgery are listed here. So is there any cortical opposition? Females, particularly older females, are more at risk for non-unions. Comminution, is it multi-fragments? And then finally, smokers. So, most patients are going to just come in and say, I took a fall right on the lateral aspect of my shoulder, whether it was skiing, snowboarding, off my mountain bike. And then we typically just get 2 view radiographs, an AP view, and then a 20-degree kind of tilted view, cephalic tilt. And however, you have to understand that with these fractures, you're really not getting an orthogonal view. So you're not getting a 90-degree view with these x-rays. It's very difficult to do that. Like, as you all have probably seen in the office with a shoulder x-ray, we tend to get orthogonal views, so 90-degree views, like an axillary lateral, an AP, and then a scapular Y, so we can see it in all 3 planes. But with clavicles, just understand that when you're looking at an x-ray, you're really not getting a great assessment of AP displacement. So, and that's why some of these studies, like if you look at this x-ray, for instance, that's displaced, but you don't know in which direction, and you can see this CT scan, and this is not uncommon to have displacement as shown here. So just be aware of that when you're looking at a clavicle x-ray, that you're not really, you might be being misled on the amount of displacement anterior to posterior. So this is one that came in the office some time ago. Grace, you want to take a stab at that one? What would you think you'd do here? Or what would you recommend to this patient? I know I'm putting you on the spot.
I would recommend surgical intervention with an lower IF.
You could certainly have that discussion. I think this is one that what you'd want to do, first of all, and we'll see this, is you want to measure the amount of displacement. So this area of the bone really keys into here, correct? And as if we measure that distance, it's actually the question to ask yourself, is there 15 millimeters or more of displacement or shortening? And in this case, there was less. And so I had that discussion with this patient. Some will say, hey, I don't want to take any chances. I just want it fixed. People are pretty uncomfortable with these in the first couple weeks, and oftentimes with surgery, if we stabilize them, they're actually having a lot less pain. But this is one that we decided to treat non-surgically, actually, and they went on to heal it fine. So I tell people it's either a scar or a bump. So you're going to have if you do heal, which you should, you're going to have a bump there, and just to make them aware of that. And but this one went on to heal uneventfully. Now, in a young male, I might be a little worried about them coming back another season or two later and fracturing again. And then it makes it harder to fix because you have all this callus that you have to deal with, and then plates don't fit well. So certainly it's a balancing act. But if this was, let's say, someone in their 40s, 50s, maybe not, super active, then I would say this would be reasonable to let treat non-surgically. So let's see. And then Nicole, what do you see on this X-ray? If you had to maybe say what pops out at you here.
Is that it's either like shifted behind each other, if that makes sense, or there's like a lot of callus formation or something that
right
doesn't look appropriate.
Yeah, there's definitely a lot of callus, but would you make this area doesn't look like it's healing, correct?
Correct. Yeah.
Yeah.
So a distinct line.
Yeah. So we actually this person, I think it wouldn't be unusual to see an X-ray like this in someone that maybe it was recommended that their fracture was treated non-surgically, because you can see it lined up really well, it lined up well, but it didn't heal itself. So this was actually a non-union, and we would call it a hypertrophic non-union, meaning that it's trying to heal, it's making callus, but it's just not healing, because you can have atrophic or hypertrophic non-union. So a non-atrophic one would be where it hasn't made any bone whatsoever, but there's still a non-union. This one is a hypertrophic non-union where it's trying to heal, but it just can't heal. And that's not infrequent, just again, because when you have motion at the fracture site, then they end up kind of looking like this, where unless they heal, like that last X-ray that we saw, then they kind of look like this, where it's a non-union trying to heal. So this really just needs stability. So really what we need to do here is just plate it. And once we give it stability, it has the biology present to heal it. So.
Hey, Dr. Cunningham, question kind of further on Grace's X-ray.
Sure.
With that, how you said that, it's 15 millimeters, but age and activity may play. I know ultimately it's kind of the patient's decision as to which way they would prefer to go. But if it's, like a 16 active snowboarder, skier, and it's kind of on the edge of that displacement, or even like significantly less displacement, would you highly encourage operative intervention?
Yeah, I wouldn't necessarily, because I would just have an informed discussion with the patient. I would just say, listen, our current criteria for a fracture like this is whether the fracture is displaced 15 millimeters or more, and or shortened 15 millimeters or more, and you're not there. And I would tell them, hey, this should heal. You shouldn't get a non-union, and you should do fine with non-surgical management. I might say, you're going to heal with a bump. It's not going to heal perfectly aligned. The bump shouldn't be painful. You should do fine. But I would say, with surgery, I can key it in place perfectly, and we're going to have even more predictable healing. You're not going to have a bump. You're going to have a scar, of course, and hardware in place. But and we're going to even further decrease the risk of a non-union, and probably get you back to your sport sooner.
Okay.
And so with all that information, I would leave it up to the family and the patient to decide. But
I guess how often do you see these like refractures? Say he does go on to heal and then he skis next season and falls directly. Is that is he more prone? I guess how more likely is he going to be to fracture at that same site?
Well, yeah, I think they probably wouldn't fracture here because, as we know, the strength of a bone is proportional to the diameter, the thickness here. But maybe they would fracture here, and we see it, but I wouldn't say it's honestly in a huge number of patients. But certainly, you do see those people that they come back a year or two later and they fractured beside the other fracture site. So I think if you just lay it out there for patients and let them make an informed decision, but this is one that, you know, if you didn't have that discussion with the patient and someone just recommended, I know, you know, I don't think we would do this, but maybe some physicians that are maybe a little more aggressive, or they're in a rush, or they don't take the time to just explain, and then you plate it, and then, you know, let's say they get an infection, or, you know, they don't like the numbness around the incision or something like that, then you have an unhappy patient. So certainly, I think you could go either way on this one, but I thought in this case, it's reasonable to treat it non-surgically.
Sure. Thank you.
Oh, sure. Yeah. So so we talked about the amount of displacement, 15 millimeters or more. That's kind of, you could even go to 20, but I'd say 15 to 20, somewhere in there. Any other indications that anyone can think of? Camille, I don't know if you're on, but do you have any other ideas of when you might have to fix a clavicle fracture?
So displacement and then the shortening, which we've been talking about.
Yeah.
And then rarely, but if there's any like other injuries associated with the fracture.
Right. Yeah, if it's like a multi-trauma, let's say they had a femur fracture and they, you know, or they had lower extremity trauma and you needed to get them up and mobilized, you probably would want to fix their clavicle so they could be on crutches or a walker more quickly. Right. That's a good one. So yeah, we talked about that. One point to make is, you know, if they heel shorten, then you get the scapular dyskinesia where they can get periscapular pain down the road, like, you know, a year later, 2 years later, and that can persist. So it just changes the shoulder biomechanics, and that's another reason why we want to fix those that are displaced, shortened 15 to 20 millimeters or more. So open fractures, they're very rare. I don't know that I've ever seen one, honestly. You see them occasionally where the skin is tented, like there's a, you know, a fracture fragment that's tenting the skin, but I don't think I've ever even seen an open clavicle fracture. They're rare. Neurovascular compromise, you know, if someone had maybe obviously some vascular compromise and you thought that it was in part due to fracture displacement, I think you would fix that. Again, I think this is pretty rare. If someone had some nerve injury alone, you might even watch it. So, but things to, you know, there's some studies that would suggest that you want to avoid it, and in even some work comp patients are unemployed, the results are not as good. I don't know. We don't really see that up here, but, you know, I think they're getting to is there secondary gain or things like that. We don't really see that much up here, but that's reported in the literature. And then you may want to avoid it in a smoker who, you know, it probably might get a non-union without surgery, but they might get a non-union even with surgery because their biology is certainly compromised. So, and then on this list should be also that multi-trauma patient we discussed, where you might want to get them mobilized more quickly. So, but this is one that, you know, you would commonly see here in the wintertime and ski season. And anyone want to take a stab? And I'm picking on Grace, Nicole, and Camille, of course, but Grace, what any description here of what you see?
I do see a midshaft
Right.
clavicular fracture. I'm assuming that the shortening is greater than 15 to 20 millimeters.
Right,
And then
I would agree.
do see some CC increase Like,
I think we're okay there. Like this distance right here, I think is okay. But you know, you can see that, like you described it well. It's mid-shaft. It's shortened. Certainly, like this area needs to key in way down here, so it's shortened. It's displaced, and then you have this big butterfly fragment right here, which is that's a common pattern. I think there's even another fragment here. So that's it. We'll see a ton of this style of fracture. You know, a snowboarder, let's say, in the wintertime. But yeah, so that one I would definitely tell the patient, hey, you know, this is very displaced, it's very shortened, you do much better with surgery. If we didn't do surgery, if someone was adamant, like, I don't want surgery, I would say, okay, you know, we can put you in a sling and see if it heals, but you have a high risk of a non-union. You're certainly going to get a malunion. So if they heal, they're going to be shortened. They're going to heal shortened and displaced. And then I would tell them, you know, you might have some chronic shoulder issues and pain as a result of it healing in that position. And then this is one too, where the skin is oftentimes tented, like these fragments are tenting the skin. I don't worry so much about them eroding through the skin, but that has been reported. So just some things to think about. So yeah, they do better with fixation of some sort, and that typically is plate fixation. So. Had a patient, this is one of my patients, you know, that, you know, typical young male that's maybe his brain isn't working too well, that, you know, went out and snowboarded like 2 weeks after I fixed him and came back with this. Gotta still protect these even if you fix them. And so yeah, these pictures are a bit old, but you know, we typically use these pre-contoured plates. Fixation is really strong, and it works well for comminution because you can take little fragments and do some lag screws and piece it all together. The hardware is not going to migrate, and then you could leave this plate in. It doesn't have to come out. Some people want it out, particularly like someone that likes to backpack, just because they have pain over the strap and things. But you could leave it in. I just throw this up for a little bit of a historical context. Like, you know, some years ago, surgeons were using some of these intermedullary devices, which they can work in a simple fracture pattern where there's just like one fracture line, let's say mid-shaft, just one fracture line, but not the x-ray I just showed you. It really wouldn't work for that. But this, it's got some downsides. You know, so it's not appropriate for that comminuted, shortened, displaced fracture I just showed you. You just couldn't use it in that setting. But then this needs to come out. So if it goes in, it needs to come out. It's sticking out the back of the clavicle back here, and so it can cause irritation right out of the gate, cause people symptoms. And when you ream the bone to try to get this thing down, you can crack it. And so I'd say they've fallen out of favor. But I remember maybe 10, 12 years ago, these, you know, there was a surgeon or two in the Valley that were using a lot of these, and I saw a couple of these, you know, that still had issues right after surgery. Like typically they were having pain where the rod was kind of sticking out of the bone, and then other issues. So I think most people are really not using these anymore. So distal clavicle fractures, yeah, these are pretty common, particularly here. And the thing to remember about these is that they're inherently unstable. They have a much higher non-union rate, so these are the types. And this, I would say, this 2A is the type that we're going to see most of the time. This is probably the most common one that we see here. So, you know, so really with this, the distal fragment of the clavicle, it's still held reduced to the AC joint. The AC joint is reduced by the CC ligaments, but you can see that the medial aspect of the clavicle, it's really nothing is holding it reduced. So you might see these come in and they look pretty lined up, and you're like, oh, I think you're gonna do okay. Let's just let this go. And then if you fail to x-ray them like a week later or 5 days later, this thing has gone really far north and it's very displaced, and there's just no way it's going to heal because there's such gapping at the fracture site. So that's the one we'll typically see the most. This one I've seen, type 5s, I've seen a couple of those too. These other ones are much less common. But this is the 2A is the one that we'll see quite often. And how to fix these. I put this up. I mean, this is these distal locking plates where you can have a lot of little locking screws, the fracture lines here. But I would say this isn't enough. As we'll see, you really need coracoid fixation. So you can use a plate like this and have some distal, like a cluster of screws out here in this little fragment. But I just had one, I think a week ago or 2 weeks ago, that was fixed with a plate like this. And he came back to see me about other shoulder issues, but he wanted his plate removed. But his AC, he basically presented with a type 3 AC joint separation where this had gone north and it had really displaced because the fracture healed, but he had a different type, but the ligaments had been disrupted, didn't heal, and he ended up with basically an AC joint separation. So, but he wanted his hardware out. But you really need to fixate the plate to the coracoid with these. So as kind of a belts and suspenders, make it even more stable. So, and we'll show that. I have a picture of something like that here. So AC joint separations, again, very common. About 40% of athletic shoulder injuries, direct force falling on the acromion typically. People are tender over the AC joint. They have that bump present. You can even see displacement depending on the type. And so our stabilizer of our AC joint, there's the static stabilizers, the capsule, the AC joint ligaments, the CC joint ligaments, the posterior superior capsule, and the CC, we have the conoid more medially and the trapezoid ligament more laterally. Then you have all your dynamic stabilizers, all the muscles around the shoulder. So, and then we still, I would say most of us still use the Rockwood types. So one's intact AC joint ligaments, just a sprain. Two, you've ruptured them, but there's only about 25% elevation of the clavicle in relationship to the acromion. Three, you've ruptured the AC joint ligaments, and you've also injured your CC ligaments, and the clavicle is 100% displaced, but it's reducible, so you can support the arm. And when you lift the arm up, you can even push the AC. You can reduce the AC joint. If we jump up to 5, it's basically 100 to 300% displaced, and the deltotrapezial fascia is ruptured, and you can't reduce it. And then 4s and 6s are very rare, where the clavicle goes posterior or it goes inferiorly. I don't think I've ever seen either one of those, so they're very rare, but they're on there. So here again, type 1, type 2, type 3. These are the ones we're going to see a lot of, and then type 5s. You're going to see actually a fair number of type 5s as well. So yeah, 1s and 2s, non-surgical, sling for a couple weeks, some physical therapy, usually fully recovered in a couple months. 3s are the ones we debate, and that's where you have to have an informed discussion with the patient and just talk to them about this. Usually I tell most patients, unless you did a lot of overhead sports or overhead work, like you're a carpenter, or you hang sheetrock for a living or something like that, probably non-surgical in a young, non-surgical, except if you're young, a lot of overhead sports or overhead work. And then I think we would just fix them. Because you can give someone a chance, like with these, and I tell people, hey, we could wait and see how you do for the first couple months, and if at 2-3 months your symptoms really haven't improved, then we can take you to surgery and fix you then. It's a little more complicated because things are kind of scarred in place, but that's an approach one could consider. So, but then the 4, 5s, and 6s are all surgical. 5s for sure. That's again the one we see. And something to remember here is that there's like 60 techniques described, and I tell people whenever there's 60 techniques or that many techniques, it means nothing works well. So, and that's true. And I would say we finally have some techniques that are working more predictably, but for decades we've struggled with how to fix these and have them stay reduced and heal predictably. But with newer technology and implants, we've really gotten better at fixing these. But for a long time, these have been, I remember even starting out in practice, these always kind of worried me because, again, nothing worked that well and there was a high failure rate. And I tell patients, listen, we can do surgery, but there's like a 25% failure rate, and that's not a great failure rate. So, and the things that predispose to failure, age, sex BMI, you can see all this stuff, but again, it gets down to the fixation methods historically weren't that great. But now, like this is a patient of mine. So Nicole, what do you see here?
So it looks like there's some damage to the AC ligaments because it's elevated. The distal end of the clavicle is elevated. And I would suspect maybe CC ligaments as well, because there's a significant difference in distance displacement between the two.
Right. I mean, you could get an X-ray, just like a chest X-ray, where we see AC joints and measure side-to-side difference. And you know, this one would be at least, this interval would be at least double what you would see on the other side. So at least 10 to 15 millimeters greater displacement than the other side. But you can see, of course, that in the ER docs will send us things, and I think our ER docs are excellent, but in some ERs they'll say, a patient will come in and they say, oh, they told me I had a type, 3, and it'll be this X-ray. They'll say, oh, you have a type 3, so you don't have to have surgery. Well, this isn't a type 3, right? A type 3 would be where the bottom of this bone lines up with the top of your acromion. So if the top bottom of this bone was down here, that would be a type 3, right? Because that's 100% displacement, because the bottom of this bone should line up with the bottom of your acromion here, right? So if it lined up with the top, that's 100% displacement, but it's way beyond that, right? So this is like 300% displaced. So definitely a type 5. And this is one, again, that just will not do well without surgery. And so, we got to get this surgically repaired, so that, and the best time is acutely, like in the first couple weeks, so that the CC ligaments that are obviously disrupted can heal. And then if you get it down acutely, the AC joint ligaments could even scar in and heal too. So, and this is kind of a construct that there's been some adaptations, but this is a similar construct to what we would use today, where there's basically a washer here, and there's a strong suture in between. This is kind of mainly what I use today. So washer, and these fiber tapes, usually 2 of them, really super strong, because you need strength here, because these implants see so much stress that they can fail, stretch out. So that's a good one. And going back, remember those type 2A fractures that we saw? You could use a plate up here to plate the fracture with some locking screws out in here, but then you need a construct between the plate and your coracoid, and it would be something like this to back up your fixation. Because otherwise those little screws that are holding this little fragment could rip out, and then you're back to where you started, where this part has got a plate on it, and you have displacement here. So. And another thing, this has been around forever, it's called a hook plate, and I still use it. It works well. I mean, and so if you have someone that, like I had a patient not too long ago, and I want to, he basically said, listen, I can't, because if we did this construct, unfortunately, I tell people you have to be in a sling for 8 weeks. Ligaments takes longer to heal than bone, like a clavicle fracture. So you have to be in a sling for 8 weeks. You have to hold the weight of your arm, which, your arm weighs about 25 pounds. It's going to stretch this implant. And some people look at you like, well, I can't be in a sling for 8 weeks. I'm going to lose my job, as let's say I'm in construction, and I can't be out, because it's 8 weeks in a sling, and then it's like usually a month or 2 of physical therapy to get your strength and your motion. So you could use this hook plate. It's super strong. Yeah, I had an ER doc in Summit who we fixed his distal clavicle fracture with this. You can see here it's a little dark, but he's got basically a 2A, and we used this hook plate. And then he went right back to work, and I said, your sling's optional. You could come out of your sling, when you're comfortable. And he was out of a sling in a couple days, using his arm, not heavy lifting, but using his arm. And so it's super strong. The only thing is you got to take these out, because the hook will erode through the acromion. So I tell people that, leave them in for 3.5, 4 months, and then we have to take it out. So it's 2 surgeries, but it's super strong. So this is a really good option in some patients. And the other patients that I'll use this in are like chronic cases of like even a type 5 AC, like we saw here. If someone came in and they've said, oh, I had this injury 2 years ago, and I never got it fixed and my shoulder's driving me crazy, we could use a hook plate on this. Usually what I'll do though is we'll wrap an allograft around the coracoid to give it some biology as well. But that's another good indication for a hook plate, a chronic type 5 AC. So proximal humeral fractures, very common. Again, we don't see them as much here in the typical patient. The typical patient is usually older females, like 75-year-old female, falls in her kitchen, fractures her proximal humerus. And we see some of that, of course, but what we tend to see this in is like the 25-year-old male who launches himself off a huge jump and fractures his proximal humerus. So it's a different animal. But you know, it's not an insufficiency fracture in the patients we see it in. Typically, it's someone that just has a high energy fracture of their proximal humerus. So, and usually in the elderly patients that have these, usually it's non-surgical management because, again, the bone is really poor quality. They're osteoporotic. The bone is really soft. You know, it's, again, like the density of the bone. Remember, you know, our weight-bearing bones, like our femurs and things, you know, are much more dense bone, right? And so in these proximal humerus fractures where they're really not weight-bearing joints, in general, they're not very dense to begin with. And then you add age to that, and the bone is very thin, and it's not amenable to fixation devices. You know, fixation devices will start to fail, and so these are typically, you know, if I have an older female with a proximal humerus fracture that's even significantly displaced, and I wish I had the X-ray. I had one recently. They do pretty well, even if they heal with angulation and displacement. So you can accept a lot here, and patients can still do well without surgery. So, but if the young patient that's kind of exploded their proximal humerus, those we fix. So yeah, the Rockwood classification, I mean, things we assess for is the amount of displacement of the head on the shaft. Is it 45 degrees or more angulated? Is there more than a centimeter of displacement? There's, again, 4 parts of the proximal humerus: the head, the shaft, the lesser tuberosity, the greater tuberosity. So we kind of classify these in large part as 2, 3, or 4-part fractures. There's an AO classification as well. The trauma guys use this. I would say in the community, most orthopods don't use this. Most of us use, again, like we will say, a 2 or 3 or 4-part proximal humerus fracture. So again, yeah, 2 parts, usually non-surgical, 3 and 4 parts. If they're valgus impacted, meaning the head is kind of crunched down on the shaft. Again, we usually don't treat those surgically, but things to think about if the greater tuberosity is off. So if someone has an older person typically has a dislocation out skiing and they rip their greater tuberosity off, their cuff basically rips it off, and those they can get impingement if we don't you know, if the tuberosity is up, you're going to get impingement. So if it's 5 millimeters or more displaced, we would want to fix that. Or if it's in a younger person, if it's a 3 or 4 part that's really displaced, we'll fix those. So, but here's one I saw some time ago. And Camille, you want to take a stab at this and just see? Let me know what you see here.
Yeah. So, it's definitely proximal humerus fracture. I don't know how you would determine what parts are involved for this.
Well, yeah. So would you say like I would say the fracture is right about here, correct?
Yeah.
So okay, and then so yeah, I would say like their greater tuberosity is up here, and it looks like it's intact. I would say that,
Right.
that this doesn't involve the greater, and then their lesser is right here, and I would say that that's intact as well. So this we would call and so it's really how many pieces really, and we'd have this segment here, correct?
Mm-hmm.
And then the shaft segment. So you'd call it probably like I'd say 2-part, right?
Okay.
A 2-part, like if you had to describe this, I would say it's a 2-part proximal humerus fracture because you really have this head segment with the tuberosities attached, and then the shaft segment. So, and we call this area the surgical neck of the proximal humerus. So,
Yeah.
you could say it's a two-part proximal humerus fracture at the surgical neck. Like if someone said it's a two-part surgical fracture, which would be really unusual, but if someone said two-part surgical fracture at the anatomic neck, that's really one in which someone fractures right at the articular margin. So basically the whole articular portion of the head has displaced itself from the shaft. That's a really bad fracture, but we see those sometimes. So this is below that. And the reason that this is less severe than one up here is because there's just more blood supply here, so these can heal more predictably. So yeah, I'd say two-part proximal humerus fracture. I'm only showing you one view. You definitely would want to see other views because you could say, I would call this one mildly displaced. You know, there's a little displacement here. You can see there's a little displacement here, but mildly displaced, and certainly you'd want to verify that on those. Remember, we talked about you want to get 90-degree views. So you want to see an axillary lateral if possible, and a scapular Y view just to make sure that the head isn't displaced from the shaft, because you can get fooled on these. So, and this is one we just let heal without surgery, and they did fine. So this is their X-ray a number of months later. So, but yeah, as we talked about, like you can see stuff like this, where like this is the X-ray. And you might say, oh, that looks pretty good, you know, and this is obviously a kid who's still maturing, and you might say this looks pretty good, but this is their CT scan, and you can see how displaced the shaft is in relationship to the head. So it's important, again, to get those three orthogonal views at the very least. In this case, obviously a CT was done, but just to remember that they can look good on an AP view, and you can get fooled. So this is one I had some years ago. I'm not sure if this video is going to play. Oh, maybe not. Darn it. Yeah, I mean, the other thing, it just, and I'm sorry, this isn't, I don't think it's going to play, but another thing to be aware of is proximal humeral fracture fracture dislocations. So this is one in which not only was it fractured, but the head is displaced out of the glenoid. So you can see these two. They're definitely, obviously need surgery, and these are tough because like sometimes things like this, even in surgery, it's hard to get the head reduced into the glenoid. Even opening them up, it's really hard. So, but just another thing to be aware of. And then usually the management of these proximal humerus fractures, again, we talked about they're mainly non-surgical, particularly in the elderly, but in a younger person with severe displacement, typically it's this construct, you know, a proximal humeral plate, locking screws. These plates are all pre-contoured, so they fit the proximal humerus really well. And then you want multiple points of fixation in the head. Oftentimes we're putting suture in the tuberosities to get those all keyed in as well. Sometimes, you know, like let's say you had that kid like this might be amenable to a couple screws in a kid, you know, maybe that's not that trustworthy. I might still plate it because you get better fixation, but you could consider a couple percutaneous screws like this. And this is nice because you're not passing the physis with a lot of different screws, and it's just a couple little stab incisions on their lateral shoulder, and you know, these can work well. They have, you know, a young person has really good bone, so you could certainly consider something like this in a kid. And then of course in an adult, like let's say, you know, an adult walks in with a fracture like this, you know, I'll be on the phone with Max, and Max, I got one for you. And then it's probably arthroplasty. But for the most part, we try to avoid arthroplasty in anything but the most severely displaced proximal humerus fractures, because the outcomes are better when you get the tuberosities to heal to the shaft. Like this construct requires, for a good outcome, that the tuberosities and your cuff attachments have healed to the shaft. And so if you do this acutely, like I don't think this is unreasonable, but you gotta suture down the tuberosities and suture to the implant and kind of cross your finger that it heals, because they might not do well unless your tuberosities and your cuff, your tuberosities that have your cuff attachments healed to the shaft. Without that, they're not going to have a good outcome. So sometimes you might consider, maybe not in one like this, but where you actually do surgery to get the tuberosities to heal, and then if need be down the road, like let's say they get avascular necrosis like this, you can see there's basically an anatomic neck component here. So they've disrupted the blood supply to the articular segment. So that might go on to necrosis, and then they might end up with this. But if you can go in having had the tuberosities heal, the outcomes are better. I think that's it. Any questions, you guys, at all?
No,
Okay.
thanks, Dr. Cunningham.
Great. Okay.
Thank
Well,
you.
thanks for joining this morning.